Hi, I'm Dr. Richard Santucci. I'm a senior surgeon at the Crane Center for Transgender Surgery. I'm a reconstructive urologist, and I'm here to talk to you about urethral stricture repair. So, repair of urethral stricture or narrowing actually has dozens of different surgeries that can be performed, but I'll be discussing the two most common procedures today. Anastomotic urethroplasty, where the bad part of the urethra is removed and the two good ends are put together, and a staged Johansen type urethroplasty, where a medium-sized operation is performed. 6 months later, another medium-sized operation is performed to fix the stricture. The urethroplasty surgery is basically done to fix narrowing of the urethra that causes voiding or peeing problems. The alternatives to the procedure are to do nothing, which is never that great an alternative for somebody that can't void well. We can actually go in and dilate or stretch up the stricture, but the problem with that is that it never lasts very long and may only give relief for days, weeks, or at the very best, months. So urethroplasty is considered a more permanent treatment for this problem. I suppose that there are some patients who have such problems with the urethra that they might elect to divert the urine, meaning getting something like a perineal urethrostomy, which is a small hole in the perineal area underneath the scrotum where the urine comes out of and the patient has to sit to pee for the rest of their life, but most patients don't elect that. The risks of this procedure are the same as any surgery, of course, which is bleeding, infection, the need for reoperation, pain or discomfort, and perhaps complications that are rarely reported or are never reported and unexpected from the procedure. It could be that you invent your own new complication, and we'll identify that and help you with that if that happens to you. The specific complications associated with this operation have to do with mostly failure. For example, anastomotic urethroplasty is a one-stage operation that's very straightforward, unfortunately has a very high failure rate of up to 30%. The staged or Johansen urethroplasty is inconvenient because it requires 2 surgeries, but has a much higher success rate, maybe 95%, with only a 5% failure rate. The expected outcomes of this procedure are permanent ability to void without problems or discomfort or infections or any other problems you might be having from your stricture. The implications of not operating can be pretty severe in that many people's stricture symptoms are quite severe, all the way up to the point of causing urinary retention, which is painful, dangerous, and even life-threatening. So generally, it's a pretty important surgery to get buttoned down and taken care of. So let's talk about the anastomotic urethroplasty in detail. So in this operation, you'll be gently put to sleep by the anesthesia team, and usually in an area in the upper scrotum. And the reason why I say that is because that's the most common result or the most common location for urethral stricture after phalloplasty. It's between the part of the urethra that was built that goes up the perineum and the scrotum and the separate part of the urethra that was built inside the phallus. It's that connection point that fails. In that operation, a perhaps 2-inch incision is made in the upper scrotum. The urethra is identified by placing a scope through the center of the urethra and seeing where it is on the inside and being able to feel that scope on the outside. And then the narrowed or bad part of the urethra is removed, and using very fine sutures, the good ends of the urethra are connected together. Then the scrotum is closed in multiple layers to give the highest chance for good repair of the urethral fix that you've just had. This procedure always requires a suprapubic tube, which will stay in for about 3 weeks, period. At a point in the surgery, the telescope will be advanced all the way into the bladder, so we'll be able to see the rest of your urethra and make sure there are no other urethral problems that need attention. The bladder will be filled to its capacity, and a suprapubic tube will be placed through the skin of your lower abdomen. Most people don't know that the bladder goes all the way up to the belly button, so if we place a tube through the skin of the belly, it goes right into the bladder itself. This is generally a safe procedure, and we've done hundreds, if not thousands of them without difficulty, but there are rare complications of this procedure. Sometimes it's possible to injure the intestines or other organs around the bladder during the placement of the suprapubic tube, and that can be very severe and even require big abdominal or belly surgery to fix it. Now let's talk about the staged or Johansen urethroplasty. So in this procedure, let's say we're still talking about an upper scrotal location. The skin and then the urethra are incised. So the urethra is a tube, and we're going to open that tube up like that at its narrow point. Then we're going to harvest skin grafts and place skin grafts around this opened urethra. And in that way, we're going to build a lot of extra building material next to the urethra, so that in 6 months, what we do is roll that back together into a larger size urethra. This does require 2 procedures, but has a much higher success rate of, we would guess, something like 95%. So after the urethra is opened and the skin graft is placed, generally a urethral catheter is left in, not a suprapubic tube in the first stage, and a very unusual dressing called a bolster dressing is placed. This is a dressing that's actually sewn down to your body and provides gentle pressure on those grafts so that they take maximally. The good thing about a bolster dressing is it requires no attention. You can just leave it alone, and it's generally removed in the clinic the following week. After the bolster and catheter are removed, you'll then be peeing out of that hole that we made. That takes some adjustment for a while, but all of my patients have figured out how to live with that, whether that means sitting to void for 6 months. Some people can stand, perhaps by pulling their phallus up one way or the other. Everybody sort of figures it out. Wound care for this area only requires that you place a little bit of antibiotic lotion like Neosporin or Polysporin on that area every time after you void. So we are using a skin graft for this. So generally that's harvested from another part of your body. If you've had an ALT, I will harvest it from the upper portion of the ALT donor site scar so that you won't have an additional body scar. If you've had a RFF, a forearm phalloplasty, then we can discuss together what would be the most convenient place to remove the tissue. Generally, I remove a piece of skin about the size of my thumb, and then I close that together, so wherever it's taken, you'll have a small incision point. So after at least 6 months passes, that allows all the tissue to heal up completely and be ready for subsequent surgery. Then we do the second stage Johansen urethroplasty. In that case, a suprapubic tube is placed, just as I explained before, and the edges of that opened up urethra are incised, and the urethra is rolled back together. But now remember, we've got more tissue to roll back together, and so the urethra is much larger. And then multiple layers of closure are placed over this to make for a more thorough closure. Rarely it can be, especially in patients with a real propensity for scarring, that when it comes time to have the second stage urethroplasty, it becomes clear that those grafts have really scarred down. And rarely we have to do an additional stage where additional grafts are placed in, another 6 months has to pass, and then the second stage urethroplasty is done. That can be disappointing, but necessary in a small number of patients. After the procedure, the suprapubic tube is left in for 3 weeks. Usually, your skin is closed with standard sutures that dissolve. Almost all of our sutures don't need to be removed. And then I will place a special biological glue over the top so that you can take a shower immediately and don't have to do any special wound care to the area in the upper scrotum. It is possible to do other surgeries at the time of the urethroplasty. So this might be a good time to have a glandsplasty or a redo glandsplasty. I suppose the only operation that it's really not possible to do at the same time is a penile prosthesis. Penile prosthesis is sort of a hyperclean surgery with a unusually high infection rate, and so we don't want to do another surgery in an only clean area. Surgically speaking, the urethra is considered clean because it's more difficult to sterilize, just like your mouth or eyes or ears would be. And we don't like to do the hyperclean penile prosthesis at the same time as urethral surgery. Preparing for this surgery, other than waiting enough time for the tissues to be ready for a safe repair, involves getting a urine culture. This isn't just a urinalysis, but an actual culture where the urine is sent off no matter what the urinalysis findings are, and we see if there's any bacteria growing in there. Sometimes we'll add a swab of the open urethra before a second stage Johansenurethroplasty just to give us extra information about the kind of bacteria you may have growing normally on your skin. We'll always give you antibiotics before the procedure and have you continue it after the procedure. That's pretty much it. You know, there are different ways to handle urethral stricture, so it's quite important that you understand from your doctor what the specific surgical plans are for you, because they may differ a little bit about the two main categories that I've just described. Thanks.